The CQC also should really incorporate into all of their assessments child health equity as well. I was really intrigued by the challenge of transforming the largest children's charity into a health and social care organisation and really building on the fantastic services that Barnardo's already had. Last year we supported 350,000 children through 650 services. We found was that a lot of the families that were referred to us were referred for non-clinical health needs because of their housing circumstances. Teachers really noticed a difference in terms of school attendance, engagement, the emotional regulation of children. We've got neighbourhood models at the moment that could use children's social prescribers as navigators because we know it works. 97% of people that came said that they wouldn't come back for the same issue again to A&E once they had had an intervention from our family support worker. Initiative like Neighbourhood Health, for example, should have co-production involving children and young people at the heart of it.
Voices of Care, the healthcare podcast.
Welcome to Voices of Care. The UK is the sixth largest economy in the world, yet poverty is increasing and deepening, with 4.5 million children currently in poverty. Barnardo's is a household name in the battle against poverty. I'm therefore delighted to welcome our guest today, its Head of Healthcare, Rukshana Kapasi. Rukshana, welcome to Voices of Care. Delighted to have you join us.
Thank you, and really good to be here.
Well, I should start actually, if I may, because last month at the beginning of the year, you were awarded an OBE for your services in transforming care and giving voice to patients as well as health equity. So fantastic achievement, and you must be very proud of that.
Yeah, definitely.
I wanted to talk about Barnardo's. I know we're going to be talking about some of the work that you're doing, driving that integration with health and social care, but Barnardo's is a household name, 150 years plus, 160 years nearly, I think. But we've seen statistics coming out showing that 6.8 million people are living in deep poverty. We've had government statistics saying 4.5 million children living in poverty, which is really a scandal in many ways. It must be an unbelievably busy time for Barnardo's as a whole, because this is the area that you've been dedicated to as an organisation throughout since inception.
It is a really busy time, and we were absolutely delighted last year because we've been at the forefront of campaigning for the cap, to end the cap on the two-tier benefits. And, it was just amazing that happened. And we're doing a lot of work. It's one of our key planks within our strategy to really continue to make more changes in this area, because I think that this is only the beginning in terms of poverty. And poverty really affects, a child's chances right into adulthood. The statistics and the evidence are really, really clear. We run a fund within the charity that really supports families who are in our services to afford some of the basic essentials. But I think the most important thing that we do is actually work with others in terms of the coalition that we've set up with other charities, because no one person can actually tackle this alone.
No, I agree. And on a personal note, I'm someone who grew up in poverty. So the work that you do has a personal and professional resonance with me. And just a moment in terms of the scale, because Barnardo's name's literally, there isn't anybody, I'm sure, who doesn't know the name. But the scale of the service, I think you've supported hundreds of thousands of children across hundreds of services.
Yeah, absolutely. So last year we supported 350,000 children through 650 services. And our services cover a really broad range of areas. So we've got 75 family hubs where we really help parents navigate a whole range of parenting challenges that they're facing, but also put them in touch with other services as well they may not have access to. We support and promote mental health. We support people who are experiencing abuse and really help people who are leaving care, finding their own feet through, things like our gap homes. So it's a real broad cross section.
And before we go into your area of expertise, I just wanted to step back because it's always interesting to find individuals and their story. You've obviously got the OB for the amazing work that you've done over, I hate to remind you, 30 plus years. And sometimes the inspiration to enter health and social care is different for different people. But I think from your perspective, I think you started in as nursing, but it was something much more closer personally in terms of your mum and how she experienced the healthcare service that I think drove you in the first place.
Yeah, so my mum has Crohn's. She's had it for many years. And so as a child, I saw her going in and out of hospital, receiving lots of treatments, sometimes, quite aggressive surgeries that she really didn't understand properly. And it gave me such a great insight into actually what needs to happen within the NHS, what we need to do differently, and how it can also be more equitable as well. So that really laid the foundation, for my journey. And then later on, I had a son with quite a complex condition as well. And that again then really gave me an insight into the join up between health and social care and where people can fall through the gaps. And actually, when you only look at somebody's health condition in isolation and don't think about the impact on education and things like that, what a missed opportunity that is.
And I think, obviously, we mentioned earlier, one of the key things that you've been recognised for is the patient voice. And just touching a little bit on your history, anyone who goes to hospital will be able to access patient advice and liaison services. I think that was an area where you played quite a big part in terms of some of the work you did.
Yeah, so I was really fortunate to work with the Department of Health in actually evaluating the first 12 PALS Pathfinder sites that were in the London hospitals. And as a result of that evaluation and that research, they were then rolled out, right across England, which is phenomenal.
And then you've talked about that joining up. You joined the charity voluntary sector. I think you've worked with Macmillan and other big names. And I guess one of the big things is the idea of connecting. And Bernardo's, I guess, appealed to you because of that very reason when you joined. I think we're 5.5, nearly 6 years, I think, since you joined.
Yeah, so I was really intrigued by the challenge of transforming the largest children's charity into a health and social care organisation and really building on the fantastic services that Bernardo's already had. That was really finding that sweet spot around complementing, strengthening, and supporting the NHS. But, all of the work that I did in all of my previous charities. Um, was really work that was quite creative, enabled you to really bring together people from all across different systems to affect some really transformative changes that are lasting, like the work that I did with Crohn's and Colitis UK, where I chaired some of the most powerful royal colleges like the Royal College of Surgeons and Physicians to come together, work with patients, produce a set of holistic standards, and actually involve patients for the first time assessing their services. And those standards are still there in the 223 IBD centres.
And Bernardo's made the strategic intent very, very clear to become a truly health and social care children's charity. I guess the timing is really exciting for you. We're going to come on to some of the impact of your work in a moment, but talk about that strategy, because if you put it in the policy environment, children's health has been absolutely promoted in the policy documents of the 10-year health plan. Obviously, the child poverty strategy. We've had attempts in the last 15 years, as of course you'll know, Child Poverty Act in 2010, which have not really succeeded. The government has now made a very big commitment to lift hundreds of thousands of children in terms of out of poverty, higher incomes. So an exciting time for you to integrate into that wider landscape.
It is really exciting because I think for the first time you've got this really bold ambition to create the healthiest generation of children. And some of those changes then that are embedded in the 10-year plan that really is supported by some of the policies that the government has put in place, like the child poverty strategy, like the Best Start in Life strategy. that address some of the social determinants of health, and really give universal access to services, for the first time. So that commitment is there and that join up is there in a way in which I've not seen before. That really gives us an opportunity, I think, to make that kind of left shift that, we're all talking about at the moment, that we know is the right thing to do, to really locate services in neighbourhoods where people can access services better. And it just makes more sense, for patients, for people who are providing services, and, for commissioners as well.
And you say, obviously, clearly support the governments. I mean, who couldn't? It's a fabulous vision that they have over the next few years. But I think you've gone on record, and Bernardo's have gone on record, that actually, even beyond that, you want to go further. Tell us a little bit about them, the other things that you want to say, particularly around measurement and accountability for these things.
Yeah, I think that one of the things that will stop the ambition turning into a reality is that at the moment we haven't got any metrics around, well, what does the healthiest of generation look
Mm.
like? And we know that actually we value what we measure. So there's lots and lots of things that are not measured in community services, in primary care, and that join up isn't there. So we're really looking, I think going forward for that to happen, because otherwise, children will just, fall off the priority list again and just be an extension of the adult population, which I think they have been for so long.
Well, I think that advocacy piece is important. If we look at the last 25 years, the attempts that have been made and not been able to be delivered, this is the time. I guess metrics will tell the truth about if there has been progress or not. You talked about the left shift earlier, the 10-year health plan, of course, one of the three key shifts. I'd like to delve into some of the detail around the work that you've done leading the health transformation at Bernardo's. And we'll stay with neighbourhoods because that's central to the government's vision, neighbourhood health centres and models and all of the plethora of policies coming out. You're quite excited about an initiative that you're developing for children and young people in terms of working with GPs. I think, is it in Birmingham?
Yeah, so we've formed a partnership and we launched it in January of this year.
Great.
So it's very new,
Mm.
with the modality GP group. And we are working with a couple of practices, and we've introduced family wellbeing workers into those practices who are targeting families through the data system that GPs have got, but also through referrals, to really target families that are most in need, to target those that are living in the most deprived community postcodes as well. To give them support, to navigate them to services like, family hubs, etc. And to really think about, if they are experiencing, kind of poverty and a whole range of other areas, what else we can do.
And I think to bring that to life, I think to expand, because you've worked really closely with all of these different services, that picture, a strategy is a piece of paper which, however well intentioned, poverty really weighs on individuals. It brings stress and anxiety. And actually, part of the work is just to be able, because my mother, when she was ill and she's got comorbidities, I'd like to think I know a little bit about the health and care system. I found it bewildering trying to navigate between the two. I guess just being able to signpost parents supporting children and young people to the right services helps to alleviate some of that stress.
I think it really does. And we've developed actually quite a lot of services. So, the GP modality
Mm.
model that I've just described was actually based on a service that we ran across 7 NHS regions of family support
It's in
workers.
the emergency
It
departments.
was in emergency departments, and it's using exactly the same model of family support workers. And what we found was that a lot of the families that were referred to us were referred for non-clinical health needs because of their housing circumstances, because they had rats and mice, crawling on the floor. They weren't able to sleep. resulting in mental health issues, or the damp and mould meant that they came 17 times in 6 months to A&E for respiratory issues and things like that. And sometimes people just haven't got the strength to do their own advocacy when they're living in those circumstances. And that's where models like, our family wellbeing workers, family support workers, can really enable them to get into a different situation.
And in an era of very tight budgets, the macroeconomic environment is not exactly fantastic. And we have, yes, increased budgets for the NHS in the recent settlement, but they are below historical average standards. That idea, I think the stats show that the group that are the most prevalent in turning up to A&E are babies under 1 and also 0 to 4. So in a sense, this contribution also supports the budgets within the emergency department resources.
It really does. And actually, there was a piece of work that the Institute of Health Visiting did, and they reported in December 23 in northwest London, one particular area. They found that 60% of babies actually coming to A&E were then sent home, reassured they didn't need any sort of clinical intervention, and that was costing 1.8 million a year just in that one
region.
London borough alone. So I think that, if organisations came together to really look at where that money is being spent and what we could do differently, instead of using really valuable, expensive clinical time, consultant time to deal with these issues, we could really see a difference in some of the pressures that the NHS is experiencing.
And I know it's not an exact science, but there is plenty of research done. For every £1 spent here, potentially there's a return of 3 times that, I think, in terms of the budget.
Yeah, so our family support workers, the independent evaluation actually showed that 97% of people that came said that they wouldn't come back for the same issue again to A&E once they had had an intervention from our family support
Yeah.
worker. And actually 82% of staff said that it really did reduce pressure. But our return on investment calculation showed that, yes, for every £1 invested, it was saving the system £3.05. So that's pretty incredible.
So, Rachel Reeves, I know there's pressure. That's a pretty good return. So interesting to see, again, the joined up services and informing prevention. Really, really interesting. I wanted to stay with some of the impacts around the family hubs and the digital access, because again, poverty, we all take for granted smartphones, 4G or whatever level of network we have, but there are groups in various postcodes that have less access. I think that's been a high priority for Bernarda's and your work.
Yeah, one of the things that we've really tried to do is to really expand our virtual family space. So this is actually our digital offer that really supports family hubs on the ground to make it more accessible to underserved groups, because we know that a lot of families can't come to family hubs between the hours of 9 to 5. So we offer weekend, evening, opportunities for people to really engage in those bite-sized programs, whether that is, dads with mental health support needs, toddler talk, potty training, and a whole range of other things like dental health and awareness as well. And what we found in Croydon, in one area actually, was that we had, up to 70 parents at a time attending our weekend courses, and 52% of those attending were actually from the most deprived postcode areas in Croydon. So I think that this model, this virtual model, is really showing that it is very, very accessible in ways in which potentially face-to-face models are not for people who are working, if you might have a disability, if that family hub is not accessible, or even, stigma as well.
And that's potentially people who might otherwise not have accessed these services, and actually with the consequences that may flow. So that's really powerful piece of advice. I wanted to look, these are services, and we're going to come back to other ones that you've developed. So I think they're really interesting around mental health. But if I pan out a little bit, Barnardo's bigger term mission right from inception has been not just the provision of services, but to get to the root causes of these differences in not just in outcomes, but in access in health inequalities. You've been working for a number of years, I think, with Sir Michael Marmot, and his work is, of course, absolutely hugely respected internationally, with the Children and Young Persons Health Equity Collaborative. Can you tell us a little bit about that? Because that's going upstream to try to tackle this challenge.
Yeah, I think that we're really proud of this work in Barnardo's because it really goes to the heart of why we're there as a charity, because we don't want inequality to undermine, a child's future. And this work really enabled us to work with 3 integrated care systems across the country, to really get them to look at the social determinants of health and think about how they could reduce inequality, through that. And what was really interesting about this piece of work was that you sort of worked with 300 children to actually develop our framework in the first place,
To hear their voices.
to hear their voices, but incorporate them in a way in which actually even Sir Michael Marmot hadn't done before in terms of the frameworks that they had developed. And what we found was that when we asked them about what matters to their health, they talked about, really that sense of belonging that they wanted to their community and to their neighbourhoods. They talked about feeling safe. They talked about the relationships and how the quality of those relationships with peers and significant adults were important. And they talked about actually just having a warm home with nutritious food. And all of this was embedded into the frameworks
That you
that then
created.
informed the interventions that the 3 ICSs used.
We can't go through all of them, but I'm just interested. We're meeting here on a Friday. I think one of the ICSs, I've forgotten which one now. There was a Friday Fun Club that was introduced, and that made quite a big impact on the local community.
Yeah, it absolutely did. So in South Yorkshire, they decided that mental health was a priority because that was the priority for children and young people. So they targeted children, younger children, aged 9 to 10. And the Friday Fun Club was an initiative with Rotherham United. And they did all sorts of activities. And in just 3 months alone, teachers really noticed a difference in terms of school attendance, engagement, the emotional regulation of children, and the fact that, children's, kind of general mental health and well-being had also changed in that time as well. And that was just 3 months of children going to, one session, which they had been involved in actually creating.
That's a dramatic impact because obviously missing school is a social issue, political issue, which is quite significant. So any turning of the dial on there. Now, Birmingham and Solihull, I was interested in the work that you did through the collaborative with Sir Michael Marmot. And there, can you elaborate on there? Because that went perhaps upstream as well to make sure that the organizations that contracted with the NHS were under an obligation to demonstrate social value. If you could just explain that, because that's really embedding it into the whole procurement structure.
Yeah, absolutely. Birmingham and Solihull really wanted to look at system change in how they, in the future, worked as a board and as an ICB. And so what they did was they doubled the social value in their supplier contracts from 10% to 20%. They weren't sure initially whether suppliers, would kind of sit back at this, accept it, but they organised a fantastic, sort of event where 100 of their top suppliers came to really introduce them to the idea. They were incredibly enthusiastic. And they are now using that to kind of divert funds into prevention by matching corporates with community-based organisations that have come up with ideas around prevention for children and young people and in other areas that they want to support. This is something that actually every ICB could do
Why
going
not?
forward.
And that then aligns a company or a supplier from whatever private sector, etc., has its own obligations, but to then align them onto these wider stakeholders, it'll be interesting to see what the long-term effect and if it's picked up by other individuals. I wanted to move. You've mentioned mental health. And this is a tremendous issue. I think 1 in 5 children and young people have a diagnosable mental health challenge. It's an epidemic, pandemic, whatever word. It's a huge issue. And obviously the government has pronounced on this and to provide support in schools. So something clearly Bernardo celebrates and acknowledges.
We were actually delighted with that commitment last year that every single child going to school would have access to mental health support through a mental health support team. Um, we also know that that mental health support team model that is not kind of accessible to all children,
Right.
especially children who are young, if you have a special educational need and disability or complex mental health problems, because cognitive behavioral therapy might be ineffective for those groups.
Right.
And they may not meet the CAMS threshold. So they're likely to be the missing middle that kind of falls through the gap. Um, but I think that, this whole area around mental health does require really dedicated focus going forward because the numbers attending, emergency departments, the Children's Commissioner in May 25 highlighted that there were 60,000 children, in crisis and a further 50,000 that were then waiting for treatment. So it's a huge area. But also, we know that there are models that can be incredibly effective as well in this area. And we have introduced a model
A
that
resilience model.
yeah, it's the Bernardo's inner resilience model. And we
Bird.
test BIRD. It's a great acronym that was actually chosen by children as well.
Brilliant.
So, this particular model we tried in a few acute hospital areas in the Black Country and in St Helens. And what we found was that providing that intensive one-to-one support that works alongside work that the family might be doing, the school might be doing, the community might be doing, actually resulted in a 2.87% reattendance to A&E. Now, the normal sort of rate is 20%. So that is phenomenal in terms of that reduction of reattendance rate, but also the outcomes too that children were receiving were phenomenal as well, and in the 90s.
So that's a dramatic difference. And staying with the wider policy prevention agenda effectively, the National Youth Strategy, I wanted to have your view on that because the government has now issued that. I think that's the first one in maybe 15 years and some quite ambitious targets, particularly in terms of health equity, reducing by 50% the difference in terms of access based on your background to services and amenities. So clearly something that you're going to work with and actually support there as well, I would imagine.
Yeah, we really welcome the youth strategy. We also feel it's really important with a lot of these strategies coming out in a short space of time that there is that join up at government level so that it works with the poverty strategy, it works with the Best Start strategy. One of the things we were pleased to see in there is that within that youth strategy, they're going to be doing more research around models like social prescribing. And we
Yes.
know through our services that we run in Cumbria and the research that we did in the Missing Link report, that actually social prescribing is highly effective in terms of reducing anxiety, increasing engagement, and most importantly, increasing school attendance as well. So this is really important, but also, we don't have to wait for that research because actually we've got neighbourhood models at the moment that could use children's social prescribers as navigators because we know it works, we know it's effective, and we should just, I think, get on with introducing it.
And social prescribing as a phenomenon over the last few years, it's been entrenched in and recognised in policy. Are you seeing a greater acceptance of its efficacy because it's now being, I think, promoted a lot more than it perhaps was previously? It wasn't even really given a name, I think, if you go back a little while.
Yeah, so it was built into the GP contract, and actually that's one of the reasons why I think there's much greater acceptance of it. The GP contract very often focused on adults in
Yeah.
terms of those social prescribing areas, and we actually know that for children, for this to work properly, it needs to be slightly different. So actually, children might not go to their GP as often, but they might tell somebody at school, they might tell their youth worker, and they might, have other places that could refer in. So it's really important that, that model is different, and actually that we have more of it, and it's recognised that that needs to be there just as much as the social prescribing link workers for adults.
To sort of close the conversation, well, just we've looked a bit at your career and what all these impacts that bananas are making. I want to look a bit of a crystal ball, looking further ahead. It's an important year. We have local elections. We've obviously got the workforce plan for the NHS. Baroness Casey is reporting in social care. So lots of policy movements, as well as the legislation around abolishing the NHS and department DHSC. I wanted to focus on perhaps two or three things that you in particular are hoping for this year in terms of the work that Barnardo's does. I know that co-production is high on your agenda, so new policy initiatives are truly given or allowed to listen to the voice of those who are receiving the services.
Yeah, I think that every new service model, service redesign, or initiative, like neighbourhood health, for example, should have co production involving children and young people at the heart of it. We know it makes such a difference, actually. If you design services with children and young people, they're more likely to work, they're more likely to be sustained, and you are going to get better outcomes as well. I think some of the other things that I'd love to see is actually the neighbourhood models that are coming out that seem to be quite clinically focused at the
Yeah.
moment, that they need to expand out into a much broader partnership model that goes beyond health. So you really are involving local authorities and the voluntary and community sector because they have so much value to add to that model. And if we are going to be person led and we're going to use the assets in the community, we need to be working with children, young people, and all of those people affected by services. um, I think some of the other things that I'd love to see is actually um, social impact and
Mm.
the economic, value of prevention really articulated in policy more,
Mm.
but also in the resource allocations that local authorities and ICBs make. This is so, so important as kind of that reset that we need to do in terms of shifting the resources to community towards prevention and all of that. And I think that the CQC also should really incorporate into all of their assessments child health equity as well.
Because I think it's perhaps not been as given the prominence that it deserves. You've talked about the prevention agenda, and I guess you've written about this very powerfully. It's of course a policy initiative, but there is also a value for money to ensure budgets are used in an appropriate way. That's going to require that whoever runs neighbourhood services must include representatives from the voluntary and social sector who speak on behalf of children and young people.
Yeah, I think it has to be an imperative, not only in terms of then the governance around it as well, the health and wellbeing boards and all of that. But I think, built into that needs to also be that economic model so that we can really see in terms of that join up where that value is, for the system too, and that it absolutely makes sense, not just in terms of outcomes, but in terms of saving the NHS money as well. And, imagine what a difference it would make if, you had a family support worker or a mental health, well-being worker in some of the models that, we've described here today, in every single emergency department, in every single neighbourhood team, in terms of how the NHS is used in the future and the pressures that the NHS, may not experience going forward.
And on that very positive and visionary note, Rukshana Kapasi, thank you very much for sharing your wisdom and insights with us today.
Thank you.
If you've enjoyed this episode of Voices of Care, please like, follow and subscribe wherever you receive your podcasts. And if you want to know more about how we're turning the dial on the health and social care debate, please visit www.voicesofcare.com. In the meantime, I'm Sahel Mirza. Thank you very much for joining us today, and I look forward to seeing you on the next episode.
Voices of Care, the Healthcare Podcast.